We're going to talk some injection site areas. We're going to start on the maxilla. And our maxillary molars is our posterior superior alveolar, or our PSA. Inject sort of a 45-degree angle, because if you try to go with the long axis of the tooth, you're going to be going against the lip, the corner of the lip. So angle in 45-degree angle, and then I kind of angle out a little bit, 45, going about 6 to 8 millimeters, giving about a third to a half of a cartridge of local anesthetic. Our MSA is our middle superior alveolar injection. Here is the injection site. It is typically above the second premolar, height of the mucobuccal fold, going in about 6 millimeters or so. Aspirating, of course, and I aspirate twice. I always do it on all my injections. I aspirate twice, and negative aspiration, we're going to give about third to a half a cartridge. Again, getting the premolars, the mesobuccal root of the first molar, all the buccal periodontium, overlying soft tissue. Anterior superior alveolar, if you look at the red area, it's going to get our central, lateral, and canine. It's going to get the same thing, facial soft tissues, underlying bone of those teeth, pulpal of the central, lateral, and canine. Onto the posterior palate. Now you look at the needle here, it's a little bit different. You see that it's kind of bowed. And that's like the secret to giving a good palatal injection. You see that the non-dominant hand is on the greater palatine foramen, and the topical is given 2 minutes. So once we've given our topical, we dry the area off, and we put the non-dominant hand, the cotton tip applicator, on the greater palatine for about 30 seconds before injecting. And at that 30 seconds, we're going to take that needle and we're going to bow that needle so the bevel's flush against the skin. Now, it's not into tissue yet. It's just flush against the skin. Give a drop, straighten the needle then, and go in and give little drops of anesthetic. When you hit the bone, back up 1 millimeter, aspirate twice. If it's negative, give a quarter cartridge. The whole time that non-dominant hand is pushing on that greater palatine foramen, and that really, really does help. Superior alveolar nerve block, or called the mandibular block. It is a true block. It covers a big area, and you're basically getting a 4-in-1 nerve anesthetized. We've got the inferior alveolar, which is a branch of the posterior division of the mandibular nerve, the incisive nerve, the mental nerve, and commonly the lingual nerve. It's very important to know the landmarks of this injection. You can't just sort of point and shoot this one. You really have to think about what am I aiming for? Where am I going? Where are my landmarks? So, that thumb or finger of the dominant hand will go on the coronary notch, having the patient open really wide, feeling that coronary notch, which is the deepest part of the ramus. And basically, where does it sit? It sits on the medial aspect of the ramus prior to its entry into the mandibular foramen, inferior to the lingula. So my dominant hand feels for the coronary notch. Then I'm going to look for the pterygomandibular raphe. You could see it in that picture there. It's actually, think of it like a piece of muscle or guitar string-ish looking, but they have to open really wide because otherwise you won't see it. So if I have my thumb or finger on the notch, I'm going to measure 3/4 from my coronary notch or 1/4 from the raphe, and that's my vertical intersection of where the injection site is going to be. So the 3 parameters I think about is the height of injection, the anterior posterior placement of the needle that helps to locate that precise entry point, and the depth of penetration, which determines the location of the IA nerve.